Welcome. This recording is based on a presentation recently given at a pre-symposium seminar for the 16th International Symposium on Schistosomiasis in Brazil. If you want to watch the full seminar, including the presentation of Dr. Perata and the Q&A session, please visit the indicated Via Cruise channel on YouTube. My name is Lisette van Lieshout. I'm a parasitologist based at the Leiden University Medical Center, and I'm specialized in diagnostic research. First of all, I would like to thank the organizers for inviting me to present our LUMC work on the diagnosis of schistosomiasis. I have no personal conflict of interest, but I should mention that our department provides the monoclonal antibodies used for the detection of CCA and CAA, which I will discuss in this presentation. What I will share with you in the next half hour is some historical work as well as some of our most recent data. And naturally, I will focus mostly on the schistosome circulating antigens, as this is most relevant for our diagnostic research. But I will also discuss some of our work on PCR and on antibody detection. And I will show you data related both to imported schistosomiasis, so in travel medicine, and data collected in endemic countries. It is certainly not my intention to give a comprehensive overview of different diagnostic techniques, or to give a full summary of everything which has been published by our group over the years. There are reviews available and you can read them if you're interested in this topic. The second presenter of this seminar, Professor José Peralta, will give a much broader overview of the different diagnostic tests which have been published. I would like to dedicate this presentation to Professor André Deelder, who till 2012 was head of our department and who sadly passed away last January. Not only was he the founder of all research on the circulating antigens CCA and CAA, he also was a great visionary on the diagnostic potentials of these circulating antigens. He was my PhD supervisor in the 1990s, and as many, I've found him a very inspiring mentor and an example for young scientists, and above all, somebody with a very warm and unique personality. His first publications about CCA and CAA was in 1976, and this was followed by more than 120 PubMed-cited papers about these antigens with his name on it. Why did he explore already in the 1970s and 80s alternative markers for active schistosome infection? As you probably know, despite all its limitations, microscopic detection of schistosome X in stool or urine is still considered the diagnostic reference standard, both in endemic and in non-endemic regions. And this is because microscopy is considered to be highly specific, and it's relatively cheap and it's a simple procedure. And an additional advantage of microscopy is that you can quantify the number of eggs. You can count the number of eggs per 10 ml of urine or in a fixed amount of stool via a cut slide examination. And this gives you, at least on population level, an indication of the burden of disease. But as you probably also know, microscopy lacks sensitivity. In particular, light infections are easily missed, and therefore sampling should be repeated on 2 or 3 consecutive days. And ideally, several slides should be examined for each stool or urine sample. And this is a very laborious task. This low sensitivity makes microscopy in particular less suitable for the diagnosis of light infections, so for imported infections or for follow-up after treatment or to monitor intervention in a community. But also on top of that, microscopy is highly operator dependent, so it's difficult to standardize. And consequently, when evaluating an alternative diagnostic procedure and comparing that with microscopy, one should always be most critical about how extensive and with which quality microscopy has been performed. So we need diagnostic alternatives. And in this talk I will discuss and show you data on 3 different diagnostic procedures. First, I will share with you some information about our nucleic acid amplification test, so the detection of parasite-specific DNA in clinical samples, which we do at the LUMC via real-time PCR. Then I will discuss with you serology, so the detection in serum of schistosome-specific antibodies. But most of my presentation will be about our work on the circulating antigens CCA and CAA. I will show you our most recent findings with the commercially available POC-CCA urine strip test, and I will show you also some studies using the in-house lateral flow test for ultra-sensitive detection of CAA. First, about the PCR we use at the LUMC. So several DNA detecting tests have been described in literature. But at the LUMC, almost 15 years ago, we implemented a real-time PCR based on the IGS-2 target. And we apply this PCR routinely, so also in our clinical laboratory, and we use it on stool or urine or genital excreta. And I know that other groups have successfully published data on other schistosoma PCRs with different targets. And some of these PCRs, as described in literature, can also be applied on blood. However, our IGS-2 PCR can only be used on, as I said, stool or urine or excreta. So in case we suspect a schistosoma mentionae infection, we apply it on stool samples. In case of schistosoma hematobium infection, we apply it on a urine sample. And if we have no idea, we just apply them on both types of samples. Being a real-time PCR, the cycle threshold value is the output, and this value reflects the amount of DNA present in the sample, which is a proxy for the number of eggs. Our PCR is highly specific by design, and this is also shown by our excellent scores in the yearly external quality assessment scheme, as published by Pete Coles in 2020. And the sensitivity of our PCR is at least as high as single microscopy. And this we have demonstrated in several publications, including an extensive comparison study between PCR and microscopy in Mozambique and Kenya, as published by Lynn Mers in 2015. But the sensitivity is not 100%, so that means large infections with low egg excretion there can still be missed once in a while. Interestingly, we found by using our PCR format in travelers that, so those who are not re-exposed after treatment, that DNA in stool or urine can be cleared within weeks following praziquantel treatment. But real-time PCR is a high-tech procedure. It's relatively expensive and therefore not suitable to be used in resource-poor settings. But despite being high-tech, PCR has major advantages if we talk about genital schistosomiasis. In women, this highly neglected form of schistosomiasis is best to be diagnosed by colposcopy, which is an invasive and unpleasant procedure. Here, detection of schistosoma DNA in gynecological samples has major diagnostic advantages, as we have shown in several studies performed in collaboration with our international experts on female genital schistosomiasis. In one of our most recent publications, in collaboration with the team of Amaya Bistundi, we demonstrated that even vaginal and cervical swab samples can be used, which were collected by the women themselves at home. So the schistosoma DNA was more often detected in these swabs than in vaginal lavage taken at the clinic. And this study also confirmed again that many, but certainly not all women presenting with FGS had an active schistosoma infection, which was defined as the urine being positive either by DNA detection or circulating antigens or X. So, in other words, only examining urine samples is not sufficient to diagnose FGS. As for molecular diagnostics, also for antibody detection, there is a whole range of different test formats described in literature, and they all have different assay characteristics. So at the LUMC, in our own clinical routine setting, we have very good experiences with 2 in-house antibody tests. This is an immunofluorescence test detecting IgM against the adult worms, in particular reactive to the gut antigens, and an ELISA detecting IgG against soluble egg antigen. But independent which antibody test you use, whether it's a commercialized test or an in-house test, many different studies have shown that the antibody responses are not related to intensity of infection or to clinical symptoms, and also that antibody tests are not suitable for follow-up after treatment. So now I will share with you 2 recent studies where we demonstrated the diagnostic potentials of our serology and in particular of our fluorescence assay. First, the controlled human infection model, where naive healthy Dutch volunteers were experimentally infected with either 10, 20 or 30 cercaria of the male Schistosoma mansoni parasite. And in this study we showed 100% seroconversion in these volunteers 4 to 6 weeks after the infection started by using our in-house immunofluorescence assay. So even in individuals exposed to 10 cercaria only. And in the graph you see here the bold lines represent the median antibody titer for each exposure dosage. Of course, appropriate treatment was given with praziquantel 12 weeks after the infection started, and we followed the volunteers for up to 1 year. And what you can see in this graph, even after a year, all volunteers still showed positive antibody levels. So early antibody responses could also be studied in a cluster of 34 infected Belgian travelers. And this cluster was originally described by our colleagues from the Tropical Institute in Antwerp, where samples could be examined already 4 to 5 weeks after exposure during a holiday trip in South Africa. Remarkable in this cluster is that 32 of these 34 showed early clinical symptoms of acute schistosomiasis. And all 34 were considered to be infected by our colleagues from Antwerp based on the fact that all of them were positive in the routine PCR as performed in Antwerp on blood samples. However, if we focus on the serology only, the picture looked remarkably different. Our colleagues in Antwerp, they use a combination of 2 commercially available antibody tests in their routine diagnostic setting. And in this cluster, where the whole cluster was infected with a schistosoma hematobium complex, these commercial tests actually didn't perform very well, and only 35% of them showed a positive antibody response. While in our in-house immunofluorescence assay on S. mansoni adult worms performed at the LUMC, we saw a much better response, with 74% of this cluster being seroconverted. But whatever serology test was used, whether it was the commercial or the in-house one, no effect was seen following treatment with praziquantel. And I will come back to this remarkable cluster later in my talk. So PCR and serology, they both have their niches, but they're not good enough to replace microscopy, and certainly not in endemic regions. So clearly there is a need for an alternative test which reflects the presence of friable worms, and also preferably in a test format which can also be used in low resource settings, so a test which is affordable and accessible. A test which is sensitive and specific, at least sensitive and specific enough to evaluate the effect of treatment. And this is where the circulating antigens CCA and CAA have shown their purpose. The names stand for circulating cathodic antigen and circulating anodic antigen. Very similar names, unfortunately, but clearly these are two different molecules. But they have things in common. What do they have in common? Both antigens are glycans and they are associated with the gut of adult worms. Both these carbohydrate antigens are constantly regurgitated by live parasites from their guts into the host circulation. So the presence of CCA and CAA reflect an active infection. And both antigens are cleared within days to weeks following praziquantel treatment. And with his early work, Andre Dielder demonstrated that both CCA and CAA can be quantified in the blood circulation, but also in urine, and the latter makes non-invasive diagnostics feasible. And their concentration reflects the worm burden, as shown in several experimentally infected animal models. Also, both antigens are very specific for schistosoma, where in particular CAA has a biologically unique structure, which makes it possible to develop even a highly specific diagnostic test. And this resulted to the development of a point-of-care strip test for the detection of CCA in urine, which was commercialized almost 2 decades ago and is still in use. The strip test includes an internal control line. The test can be scored in a semi-quantitative way, with the thickness of the test line representing the CCA concentration in urine, which is then a proxy for worm burden. But clearly this makes the scoring an observer-dependent procedure. In particular, it has been debated where to make the cutoff between trace and truly positive. Also because so often there is no satisfying reference test to determine the true infection status of each individual. Also, the reading of the strip should be done exactly at 20 minutes, which can give some logistical challenges. But because the POC-CCA urine strip is so easy to use, it became an attractive alternative to stool microscopy in poor resource settings. Numerous peer-reviewed publications have shown this POC-CCA strip test to be very user-friendly and cost-effective, and therefore an attractive alternative to microscopy, in particular in moderate to highly infected populations, and in particular for the diagnosis of schistosoma mansoni. And several studies have also shown that the sensitivity is at least as good as single-stool microscopy. But of course this also depends on the quality of the microscopy performed. And similar to the ELISA, also the POC-CCA urine strip test can be used to measure both the prevalence in a population, as indicated in the graph in the middle and on the right top, and to indicate the intensity of infection, and therefore also to monitor praziquantel treatment. And this is illustrated in the graph on the right bottom, where we see a clear shift to the low intensity test lines and so a lower score following praziquantel treatment. In 2020, the test has been recommended by the WHO as an alternative to stool microscopy for the diagnosis of S. mansoni infections, and again in particular in regions with moderate to high intensity of infection. However, its performance is rather variable for the other non-mansoni species. Also, it's important to mention that batch-to-batch variations have been noticed by us and by others, and this is probably due to the fact the manufacturer introduced some adaptations in the test format, in particular by leaving out the neutralizing buffer. In one of our most recent studies, we showed that there is in particular a specificity challenge when using urine samples of babies less than 9 months old and pregnant women, which seem to be solved by reintroducing this buffer step. Recently, the test has been CA certified, but still we cannot stress enough the importance of always including a QC system. So reading of the test line should be done with standardized reference scores, such as the pre-printed G-scores, and individual batches should always be checked, in particular when the test is to be used for babies or toddlers or pregnant women. Most POC-CCA work is done on population surveys, but can the POC-CCA test also be used in a clinical setting? Currently, studies are performed to validate this POC-CCA strip test in test and treat of infected individuals in endemic areas, with focus on small children and pregnant women, also to further explore the already mentioned specificity issues. And data is pending. For more information, please visit the Free Billy website. The performance of the POC-CCA test to diagnose imported infections in non-endemic regions, so for travel medicine, is somewhat debated because of conflicting results. The test seems helpful for the detection of chronic schistosomiasis in migrants, but again with a major limitation for implementation in routine diagnostics in Europe, because it seems only to be suitable for schistosoma mentionae. And the controlled human infection model convincingly showed that the test is not sensitive enough to detect very light as mentionae infections, so up to 30 Secaria, and therefore the test is not suitable for short-term travelers. The second test format I would like to discuss is the UCP lateral flow test for the detection of CAA. This ultra-sensitive and highly specific test makes use of upconverting reporter particles. The current test format is semi-laboratory based, and it is important to realize there are slightly different formats available, such as the so-called dry format and a wet format. And besides, its analytical sensitivity is depending on the starting volume of the clinical sample and the use of a pre-concentration step. So in other words, the higher the starting volume of the urine or the serum, the more sensitive the test becomes. And with the UCP-LF test, CAA levels can be quantified, quite precisely quantified, actually, in either serum or urine, by using a reference standard with known concentration of antigen. And the CAA is detectable for all schistosoma species. However, the test is an in-house format, and for the readout, a specific reader is needed, which makes the test less user-friendly. On the other hand, the procedure is clearly less complex than many antibody tests. And over the years, our UCP-LF-CAA test has been implemented in several laboratories within endemic countries, although mainly for research purposes. This slide summarizes the outcome of different field studies where microscopy has been compared with the outcome of the CAA detection with the UCP-LF strip test in urine samples. And in each of these studies, it is the light intensity infections that are missed by microscopy, while still being picked up by the CAA test. And one can wonder whether this is relevant for individual disease outcome if these low worm burdens are missed. But most likely it still has consequences for disease control. And of course we would love to do more long-term follow-up surveys, in particular in near elimination settings. The fact that the dynamics of the diagnostics is far more complicated when you study a population in an endemic setting, so with continuous risk of re-exposure for each study participant and the potential presence of pre-patent infections. This is actually shown in one of our most recent studies. This is the so-called REP study, which stands for repeated doses of praziquantel in schistosomiasis treatment, and you can find more information on their website. And this study measures the efficacy of 1 versus 4 repeated doses of praziquantel given with 2 weeks interval against schistosoma mentionae infections in children living in Côte d'Ivoire. It's an open label randomized controlled trial. And what is depicted here in the tables are the cure rates and the intensity reduction rate based on the measurement 4 weeks after the last praziquantel treatment and comparing 4 different diagnostic procedures. I have to say that these are still preliminary findings. We are still analyzing the details, in particular of the CAA and the PCR data. But if you're interested in to hear more, on the REPST website there is also a full presentation about this study by Pietje Hoekstra, which was recorded for the ISNTD. But what we can conclude from this table, at least, is that both single and repeated praziquantel treatment result in a substantial reduction in intensity of infection. But when we analyze absolute cure rates, it seems to make a difference whether you use a test based on egg detection, such as microscopy or PCR, or a test reflecting worm loads, like the circulating antigens. In particular, the highly specific CEA test suggests that there are still worms present, although much less, but they're still present even after repeated praziquantel treatment. Another interesting aspect of the UCP-LF-CEA test is the rather exact quantification of CEA concentrations, in particular in serum. And this is because it gives us an insight in the actual burden of infection in different populations. Here we see, for example, that the volunteers, already mentioned, experimentally infected with the male parasites, mostly show a serum concentration just above cutoff level, but except one, always less than 10 picogram per milliliter. So that's a low concentration, while populations in endemic countries show impressively high serum concentrations, as you can see on the left. Overall, the controlled human infection model gave us a lot of insight in the dynamics of CAA. Serum levels are clearly related to the number of cercaria given, as you can see again on the graph on the top left. And the higher the worm burden, the shorter the pre-patent period. Following praziquantel treatment, all except 6 volunteers became negative within a couple of weeks. And these 6 were retreated, and they also became negative within 4 weeks. And all infected negatives remained negative up to 1 year in the follow-up. The diagnostic power of serum CEA detection in live infections was also shown in 2 of our most recent publications, both testing imported infections in travelers. One was a prospective study where 106 Dutch tourists were included in a travel clinic setting. They all reported freshwater contact in sub-Saharan Africa, but they were not selected based on any symptoms. They were recruited up to 2 years after their return, but had not yet used any praziquantel after their exposure. And what you can see here is that 22 of them were found to be antibody positive in the immunofluorescent assay, indicating exposure to the parasite, while only 2 of them had detectable serum CAA levels. At follow-up, 6 weeks and 6 months after praziquantel treatment, all seropositives remained antibody positives, while the CAA in serum was fully cleared. So from this study, and in combination with the controlled human infection model, we may conclude that in many travelers with short-term exposure, active infections seemingly do not fully establish, or they have a very low and therefore undetectable worm burden. And this study also again confirmed the specificity of the serum CAA assay. The other study concerning again the cluster of 34 Belgian travelers who I mentioned before and who were all infected based on their serum PCR test and who had a very outspoken clinical symptoms of acute schistosomiasis. And what you see in this graph is the serum CAA at the right and urine CAA at the left. And in serum, the CAA was detectable actually in all individuals except one, so 97% of the cases before treatment. and 30 of them serum CA was already positive very early after exposure, so 4 to 5 weeks after exposure. And following treatment with praziquantel, the CA levels dropped really significantly in all. So in summary, yes, most of our diagnostic research at the LUMC has focused on CCA and CEA, but we think there is also a place for PCR and serology. And I think personally that in high income settings, DNA detecting tests are likely to fully replace microscopy in the coming years. But for resource poor settings, there is clearly a need for more field-friendly and affordable molecular test formats. In particular for the diagnosis of female genital and male genital schistosomiasis, where the detection of schistosoma DNA in genital excreta is essential. But as long as these field-applicable PCR-like formats are not broadly available, the detection of CCA and CEA seems to be the most practical approach, also for FGS and MGS, at least to demonstrate an active worm burden. Concerning serology, different antibody tests are available in the market, and in particular clinicians I think should be aware that they can substantially differ in the sensitivity. But with the right antibody tests, like our in-house immunofluorescence assay, those who have been exposed to the parasite for the first time in their life, they can be simply identified within 4 to 6 weeks after exposure. And I have shown you that the detection of specific antibodies can be a very powerful tool, in particular in very light infections, which can hardly be diagnosed even by the ultra-sensitive CEA test format. So at the moment we are further exploring antibody profiles, in particular against specific carbohydrate epitopes. And we hope to develop a combined antibody-antigen test, which could be used, for example, for near elimination settings. Also, I shared with you some of our most recent studies on CCA and CEA, but yeah, as I said already, 30 minutes is too short to discuss all. I hope I made clear to you that the CCA and the CEA test have a different purpose, and that also within the CEA test there are different test formats and each have their own sensitivity. So, to cut a long story short, there is no single test that fits all. The POC-CCA urine strip test proves cost-effective and a user-friendly alternative for the diagnosis of active chronic S. mansoni infection of moderate to high intensity, in particular in school-aged children. But standardized reading procedures and the right quality control steps are essential, certainly when intensity of infection drops. The ultra-sensitive CEA test format is most effective for early diagnosis of acute schistosomiasis and for follow-up after treatment. It's a powerful diagnostic tool for clinical trials and research settings, and because of its ultra-sensitivity and high specificity, it also has high potentials for antigen detection in pooled urine samples. But it is still an in-house test with limited availability. So to make CEA testing accessible, priority is given to the development of a field-friendly CEA rapid diagnostic test based on fingerprint blood. And a project has been started and coordinated by FIND, and you can read more about it on the FIND website. And such a test format will, by definition, have a lower technical sensitivity than the UCP-LF test format, but it still has the advantage of the high specificity, and it can detect all schistosoma species. Which test best to use in which setting? This we reviewed in one of our most recent papers. So logically it depends on the local settings, including the technical and logistical options, and the target population. Some last words about possible future developments. Despite more than 40 years of work since Andrew Dealder discovered CCA and CEA, we are still not there. There is certainly more to explore. We still have several basic research questions, things we'd like to know about the structure and the function of these two glycoconjugates. and we still do not fully understand the kinetics of CCA and CAA, and certainly in relation to the immune status of the host and the duration of infection, and with different schistosoma species, including hybrids, and the clearance following treatment. Then there are items concerning the operational aspects. We want to test the efficacy of pooling urine samples in endemic regions, and this might lead to better precision mapping and therefore to more efficient distribution of praziquantel. In addition to that, technology needs to be pushed, and what we ultimately need, both for individual patient care and for public health purposes, is real-time connectivity. So one of the reassured requirements. So diagnostic devices which are able to perform standardized digital readings and ideally are also digitally connected. Interesting, therefore, are the recent developments with the user-friendly automated optical device, such as the schistoscope, which can assist microscopy and ultimately even replace microscopy, in particular in settings where prevalence and intensity of infection are still high. So in the same line, we think about digitally connected automated strip readers for ultra-standardized quantification of CCA and CAA. And there is still some work to do in this direction, but some first promising steps have been made. With this final slide, I would like to acknowledge all my colleagues at the LUMC for their tremendous dedication to diagnostic research, and to all our international collaborators, in particular the field teams, who are tremendously important in collecting well-characterized samples. And many thanks to our funders who made this research possible. Thank you for your attention.